Welcome. I'm Phil Gorelick, Professor of Neurology at Northwestern University in Chicago, and I'm here today with Professor Li from China, who will be discussing a very important paper, Golden Bridge 2. Dr. Li, thank you for joining us today, and could you tell us a little bit about the study?
Okay, it's my great honor to take part in this interview. Yeah, Golden Bridge 2 trial is to focus on AI CDSS to help stroke physicians to increase stroke care quality and reduce stroke recurrence. It's a multi-center, open-label, parallel cluster randomized trials.
Terrific. So you've got an artificial intelligence clinician support system or decision support system. And what were the findings?
Yeah, we found that among hospitals using this AACDSS, patients have a lower 3 months new vascular events compared to usual care groups. Now about 1% of 1% of reductions.
Okay, so your primary outcome endpoint had to do with stroke, MI, and vascular death at 90 days, and you compared the decision support tool from AI with usual care. And you had a lot of hospitals. As I recall, there were about 77 hospitals.
Yeah.
What types of hospitals were these?
Including a territory-grade hospital, similar to comprehensive stroke center. And we also including some secondary grade hospital. It's similar to community primary stroke centers in China. Yeah.
Okay, so you had a very good group of hospitals. It seems you had comprehensive and primary stroke centers, as we would call them in the U.S. With that 1% difference in the primary outcome, was there any cost-effective analysis done by chance?
Yeah, it's important for us to conduct a cost analysis. We are collecting the data now, but we don't have the final findings to us.
Okay. I also noted that you had a secondary outcome that had to do with quality performance measures, which of course are very, very important for us. And can you tell us a little bit about your results? I think there was a 1.7% benefit in the AI cluster group.
Using our AI CDS group, we can increase the adherence rate of stroke care quality. Especially, we find that in anticoagulation therapies for atrial fibrillation after stroke, and we also increase the dural antiplatelet therapies.
Okay. Were there any quality outcomes that didn't do well?
Oh, maybe now some like standing therapy, because most of standing therapy is higher, maybe near to 99%, so they don't have increased.
I'm also interested in how easy is this artificial intelligence system and dashboard of information for people practicing? Is it easy to use? Is it easy to adapt to? What can you tell us?
This AI system was integrated into hospital information system and physician's operation system. So a physician can use this system easily. They can just click some buttons, or sometimes they need input some information. But generally, it's easy to stroke physicians.
Well, that's great to hear. Even persons such as myself could use the system, it sounds like. It's very easy. And finally, did you have any study limitations?
Absolutely. There are some limitations. I think patient's outcome is affected by another information, like an outpatient care is also important. But in this study, we don't collect the detail of outpatient cares. And then the other is this system need to be generalized in different healthcare settings. And also the AI tools also be generalized by different hospitals, and they have different images. So we need to improve our CDSS.
Yeah. Professor Li, we wish to thank you. We look forward to the formal presentation, which is going to occur at the International Stroke Conference 2024 shortly. And it sounds like we have a very promising AI decision support system for clinicians to reduce stroke, MI, and vascular death, and also to help us improve our quality metrics in the first 90 days. Thank you very much.
Thank you.